Hey there, future medical pros. Welcome back to the deep dive. This is where we try to take a whole stack of information and, really turn it into actionable, memorable knowledge for you. Today, we're diving into a really crucial area, one that, well, it literally supports us every single day. The posterior trunk and the shoulder region. It's pretty intricate stuff. Just think for a moment about the incredible work your back and shoulders actually do. From those tiny adjustments keeping you upright to the big, powerful movements like lifting or throwing, or even just grabbing something off a high shelf. It's this amazing symphony of muscles, nerves, bones. And as you step into your clinical roles, really getting a handle on this composition isn't just foundational. It's absolutely key. Key to diagnosing, key to treating so many conditions. So our mission for this deep dive, we want to unpack the major muscles back there, talk about their movements, map out the nerves and make them work, and really importantly, touch upon the key clinical things you're likely to see. Some mental anchors, maybe a few tricks to help make this information stick. So you're not just memorizing lists, but like truly understanding how it all fits together.
Yeah, and what's really remarkable, I think, is how these regions, which we often just, take for granted, they're such a brilliant example of layered biological engineering. We're going to sort of peel back those layers today, see how each part plays a really precise role, both in the big movements and in that fine-tuned stability.
Exactly. So let's start with a little thought experiment, something that often trips students up. Have you ever wondered why some back muscles feel like they're right there, part of your spine, really deep, while others seem to connect your arms to your torso, more like, I don't know, external scaffolding? And maybe even more importantly, what could possibly explain why these two groups get their nerve supply so differently? That seems kind of weird, right? Hold that thought, because by the end of this, that question should be, well, crystal clear. Okay, let's really unpack this. All right, to start exploring the posterior trunk, we first need to get our heads around a really fundamental distinction. It's vital for you as a med student. Are the back muscles extrinsic or intrinsic? This isn't just some academic label. It defines their main job and, crucially, where their nerve signals come from.
That classification, extrinsic versus intrinsic, it perfectly frames why their functions and, like you said, the nerve supplies are so distinct. It's this fundamental split. Really dictates how they contribute to movement and stability.
Exactly. So think of the extrinsic muscles as your external contractors, or maybe the movers and shakers. They actually start somewhere other than the back itself, the vertebral column. And their main job is moving the upper limb or helping with breathing to make you swing your arms, expand your chest. And the key detail here, these extrinsic muscles are generally innervated by the anterior rami of spinal nerves. Remember that, anterior rami.
Right, and then conversely, the intrinsic muscles, think of these as the core builders, or maybe the posture police. These ones develop within the back proper. Their whole focus is the vertebral column itself, moving it, and really importantly, maintaining your posture. And this group, the intrinsic muscles, they're uniquely innervated by the posterior rami of spinal nerves. Posterior rami, they're kind of the silent, tireless workers, giving that deep support and really fine control for your spine and head.
Okay, now remember that question I asked earlier about the different innervations. Why anterior for one, posterior for the other? Here's where we connect the dots. It goes back to embryology, to the epimere and the hypomere. These are divisions in the embryo that basically explain right from the start why those nerve patterns are so distinct. It saves you just memorizing, you actually understand the why. And to help lock this in, we've got a little mnemonic anchor for you. Think, PPP, posterior primary rami, supply the proper intrinsic muscles of the back. And these develop from the epimere.
Epimere, right. So the dorsal branch of the spinal nerve, that posterior primary ramus, supplies the epimere derivatives. Makes sense.
Yep. And then remember, AAA, anterior primary rami, supply the appendicular or extrinsic muscles.
Yeah.
And those develop from the hypomere.
Hypomere. Okay, so the ventral branch, the anterior primary ramus, innervates the hypomere derivative.
Exactly. So this embryological origin neatly explains the whole distinct nerve supply thing. It's a really fundamental concept, kind of unlocks the why behind the anatomy you're learning.
That's a great way to remember it. PPP and AAA clears things up.
Okay, good. So let's zoom in now on the specific players. The extrinsic muscles, those external contractors. First group, the superficial extrinsic muscles. You'll also hear them called posterior axioappendicular muscles. Bit of a mouthful, but basically these are the ones connecting your arm, your upper limb to your trunk, making all those big arm and shoulder movements happen.
And that's a crucial point because while they are powerful movers, think about their nerve pathways. They can be quite long, right? Which makes them a bit susceptible to injury. So beyond just nerve damage, what's a common functional issue you think clinicians should watch out for with these big movers and shakers?
Ooh, good question. Well, to answer that, we need to know who they are and what they actually do. Let's run through the big ones. First, the trapezius. Huge, diamond-shaped muscle. Very superficial, you can feel it easily. Defines your upper back and neck shape, its actions. Super versatile. It elevates, retracts, and depresses the scapula, the shoulder blade. But here's the clinical so whats. It also rotates the scapula upwards and outwards. And that motion is absolutely crucial for lifting the glenoid cavity of the socket so you can raise your arm fully overhead.
Right, that upward rotation.
Exactly. Without the trap doing its job, full arm elevation just isn't happening. It gets its nerve supply from the accessory nerve, that's cranial nerve ecline.
Okay, trapezius. Big player.
Got it. Next, the Latissimus Dorsi, the lats, often called the swimmer's muscle. And for good reason. It's a powerful extensor, adductor, and medial rotator of the humerus, the arm bone, like in a swimming stroke or pulling something down. But here's where it gets really interesting clinically. It can also raise the trunk towards the arm. Think about doing dips or pull-ups or climbing.
Ah, right. So it works both ways. Moving the arm on the trunk or the trunk on the arm.
Precisely. Crucial functional distinction. It's innervated by the thoracodorsal nerve. And notice this nerve gets contributions from multiple roots, C6 to C8. So a little bit of built-in backup if one root gets damaged.
Good point. Redundancy.
Then we have the levator scapulae. Name kind of gives it away, right?
Lifts the scapula.
Yep. Primary action is elevating the scapula. Also helps rotate it a bit. If someone complains of a stiff neck, tight shoulders, this muscle is often involved. Innervated by the dorsal scapular nerve, plus some direct branches from C3 and C4 spinal nerves.
Okay. Levator scapulae.
And finally, for this superficial group, the rhomboid major and rhomboid minor. They sit deep to the trap, between the shoulder blades. They work together. Key job. Retract the scapula, pull it back towards the spine, and fix its position against the ribs. They're key for posture and scapular stability.
So if they're weak, you might see issues like winged scapula, where the shoulder blade sticks out.
Exactly. Or just chronic shoulder pain because the scapula isn't properly controlled. They get their nerve supply from the dorsal scapular nerve, same as the levator scapulae partly.
Okay, so that covers the superficial extrinsics. Trap, lats, levator, rhomboids, movers, and stabilizers.
Right. Now let's move just a bit deeper to the intermediate extrinsic muscles. These guys don't really move your limbs directly. Their main gig is respiration, breathing. We're talking about the serratus posterior superior and serratus posterior inferior.
Yes, the serratus posterior muscles, often overlooked, but clinically relevant sometimes. You might see a patient describing this sharp, localized pain in their back, maybe worse when they take a deep breath or cough. These muscles, supplied by intercostal nerves, they help move the ribs. The superior one helps pull ribs up during inspiration. The inferior one pulls them down during expiration. So understanding their role can help differentiate that kind of musculoskeletal pain from, something more serious inside the chest.
Good clinical tie-in. So, okay, if the extrinsics are the external contractors for arms and breathing, what holds the spine itself together? What gives it that deep core support? That brings us to the intrinsic back muscles. These are the true muscles of the back proper. They run all the way from the pelvis up to the skull. Deep segmented support. And remember, our mnemonic.
PPP, posterior primary rami.
Exactly. Supplied by the posterior primary rami of spinal nerves, their main job, posture. And controlling all those fine, precise movements of your vertebral column.
Yeah, what's really cool here is this group provides that super fine-tuned control and the stability that lets your spine move through its complex range while still protecting all the important nerves inside. When someone describes that deep, nagging, low backache, maybe it radiates a bit with movement, it's often these intrinsic muscles that are, complaining. Highlights their constant fight against gravity.
Totally. We can actually break these intrinsic muscles down into 3 layers too. Superficial, intermediate, and deep. Each layer adds a different kind of control. Let's start with the superficial intrinsic group. This layer includes the splenius cervicis and splenius capitis. Splenius means bandage. They kind of wrap around the deeper muscles. Their actions are pretty specific. If one side contracts unilaterally, it bends the neck sideways, laterally flexes, and rotates the head to that same side, like checking your blind spot.
Okay, same side rotation. Got it.
But if both sides contract together bilaterally, they powerfully extend the head and neck. Let you look up at the ceiling or the sky.
Extension. Makes sense. Powerful neck extensors.
Right. Now moving to the intermediate intrinsic group, this is a big one. The Erector Spinae forms that prominent column of muscle you can feel on either side of the spine. Really powerful. We need another anchor here. To remember its 3 columns, think, I long for spine. Or maybe, I love spines. Whatever works for you.
I long for spine. Okay, what does that stand for?
It helps recall the columns from lateral to medial. I for iliocostalis, most lateral, connects ilium to ribs. Long for longissimus, intermediate, longest part. And spine for spinalis, most menial, right next to the spinous processes.
Iliocostalis, longissimus spinalis, I long spine. Okay, got it. And what do they do?
Crucial for spinal movement and posture. Like you said, they're battling gravity all day. When both sides work together bilaterally, they powerfully extend the vertebral column from being bent forward, like standing up after bending over. They're the main extensors.
Right, straightening up.
And if just one side contracts, unilaterally, they bend the spine sideways. Lateral flexion.
Okay, extension and lateral flexion. These must be the muscles involved in a lot of that chronic lower back pain and muscle spasm people get.
Absolutely. They work hard, they get fatigued, they get inflamed. Common culprits.
Makes sense.
All right, finally, we dive even deeper. The deep intrinsic group, the transversus spinal group. These are deep to the erector spinae. They're shorter muscles running obliquely between vertebrae, often just spanning a few segments. Real fine-tuners. This group includes muscles like the semispinalis, multifidus, and the rotators.
Semispinalis, multifidus, rotators. Deep guys.
Yep. Their main job is also extension, but maybe more importantly, stabilization of the vertebral column. They provide that really subtle segment-by-segment control.
So they're more about fine adjustments and stability between individual vertebrae.
Exactly. Think of them as providing nuanced spinal movements and maintaining stability against all sorts of forces. They're also really important for proprioception, telling your brain exactly where your spine is in space. The architects of subtle posture.
Wow. Okay, so that's a lot going on in the back. Extrinsic movers, intrinsic stabilizers, all layered.
It really is.
Yeah.
So now let's pivot. We've built the back framework. Let's leap to a region that's equally complex, maybe even more mobile, and definitely prone to issues. The shoulder, truly a marvel of engineering, but that mobility comes at a cost, right? Makes it vulnerable. Our first big player here is the mighty deltoid muscle, the cap of the shoulder.
Yeah, the deltoid. And a really remarkable thing about it is that it can perform all the major shoulder movements except adduction, bringing the arm back to the side. It has three parts, right? Anterior, middle, posterior. And they allow flexion, abduction, and extension. That versatility tells you a lot about its power. It's the prime mover for so many arm actions.
It certainly is. Big triangular muscle. Attaches up on the clavicle, the acromion, the spine of the scapula. That it all converges down to insert on the deltoid tuberosity of the humerus. And its nerve supply. The axillary nerve. Remember that one? Axillary nerve. Okay, here comes another clinical puzzle for you. A thought question. Imagine a patient walks into your clinic. They had a nasty fall right onto their shoulder. You look, and one shoulder seems noticeably flattened, like the normal round contour of the muscle is just gone. And they tell you about this distinct patch of numbness right on the upper outer arm, kind of where a small bag or patch might sit. What nerve immediately jumps to mind? And what kind of injury could cause that specific picture? Keep that image in your head. We'll connect those dots very soon.
Ooh, yeah. That description immediately brings a specific scenario to mind. It highlights a crucial clinical point about the axillary nerve's path. It runs quite close around the surgical neck of the humerus. That's the spot just below the ball and socket joint. About 5 centimeters below the acromion, roughly. And that specific location makes it particularly vulnerable in certain common injuries.
Okay, so its location is key.
Definitely. And as a really important clinical pearl, damage to that axillary nerve leads to problems with the deltoid muscle. It gets weak or paralyzed. That causes that characteristic shoulder flattening you described because the muscle loses its bulk. And that specific patch of numbness, that's often called a regimental badge sensory loss, right over the lateral deltoid. It's a classic sign.
Regimental badge sensory loss. Got it. So what typically causes this axillary nerve damage?
Most common causes. A shoulder dislocation, especially an anterior dislocation, can stretch or tear the nerve. Also a fracture of the surgical neck of the humerus that spot it runs around. That's a really common fracture site, especially in older adults. And unfortunately, sometimes an intramuscular injection given too low in the deltoid can hit the nerve. Got to be careful with landmarks.
Wow, okay. So dislocation, surgical neck fracture, maybe injection. Good to know. Right, moving on from the deltoid. Next up, the legendary rotator cuff muscles. You hear about these all the time. 4 muscles. Crucial not just for movement, but absolutely essential for stabilizing that very mobile glenohumeral joint. The shoulders, ball and socket.
They basically hold the head of the humerus, the ball, snugly within the glenoid cavity, the socket, which is actually quite shallow. Without them, the shoulder would be incredibly unstable.
Exactly. And to help remember these 4 crucial muscles, use the acronym SIT. S-I-T-S. The S stands for supraspinatus. This one sits above the spine of the scapula, its main job. It helps start arm abduction, getting the arm away from the body, usually credited with the first 0 to 15, maybe 20 degrees.
Right, the initiator of abduction, and often the first one to get injured, isn't it? Tendon tears are common here.
Very common. It's innervated by the suprascapular nerve, which comes from C5 and C6 nerve roots. Next, I is for infraspinatus. Sits below the spine of the scapula. Its main action is lateral or external shoulder rotation, rotating the arm outwards, like winding up to throw.
Okay, external rotation.
Also innervated by the suprascapular nerve, C5, C6. So that nerve supplies 2 of the SAT's muscles. Then T is for teres minor. A smaller muscle, works closely with infraspinatus, also does lateral external rotation.
So 2 external rotators in the cuff.
Yep. And teres minor is innervated by the axillary nerve, same nerve as the deltoid. Also C5, C6 roots primarily. And finally, the last S is for subscapularis. This one's different. It sits on the front surface of the scapula, between the scapula and the ribs. Its job is medial or internal rotation, rotating the arm inwards, like putting your hand behind your back.
Ah, the internal rotator of the group, and its nerve supply.
That comes from the upper and lower subscapular nerves.
Got it. Cisspinus, supraspinatus, abduction initiation. Infraspinatus, external rotation. Teres minor, external rotation. Subscapularis, internal rotation. Covers all the basic rotations plus that initial lift. And what's really key clinically is that injury to any of these can cause significant pain when moving the shoulder. And it can lead to real instability. Their tendons can tear or even pull off the bone avulse, especially with sudden force or just chronic wear and tear. Really impacts shoulder function.
Definitely.
And another really critical clinical pearl involves that supraspinatus tendon again. It passes through a tight space under the acromion and a ligament there, the coracoacromial arch. It's like the roof of the shoulder.
Yeah.
That tendon can get pinched or impinged in that space.
Impingement syndrome. Hear that a lot.
Exactly. And it often results in a classic sign. A painful arc of abduction. The patient feels pain, often sharp, when they lift their arm out to the side, typically somewhere between 50 and 130 degrees. Below that might be okay, above it might be okay, but in that arc, it hurts.
Ah, the painful arc. 50 to 130 degrees, that's a good diagnostic clue.
It really is.
Yeah.
And the pain can sometimes even radiate down the arm towards the hand. Classic sign for impingement, often involving supraspinatus.
Okay, this is great. This brings us back to full arm movement, though. Remember how we said the deltoid, powerful as it is, really only gets the arm to about 90 degrees of abduction, straight out to the side. So how do you get your arm all the way up, above 90 degrees, reaching for that top shelf? It's clearly not just the deltoid or the initial push from supraspinatus.
Right. It requires more than just movement at the glenohumeral joint itself.
Exactly. The answer involves the scapula moving on the rib cage. It requires scapular rotation. This is absolutely key for getting the arm above 90 degrees. It's a fundamental concept in how the shoulder works. Scapulohumeral rhythm.
Scapulohumeral rhythm.
Right.
The coordinated movement.
So who are the key players doing that scapular rotation? Well, our old friend the trapezius comes back into play. It rotates the scapula upwards and outwards on the chest wall. This tips the glenoid cavity, the socket, upwards.
Ah, so the socket follows the ball, essentially.
Pretty much. And another crucial muscle helping with this upward rotation is the serratus anterior. It's a muscle on the side of the ribs, holds the scapula flat, but also pulls it forward and helps rotate it up.
Serratus anterior. Okay, so trap and serratus anterior work together to rotate the scapula up, allowing that full overhead reach.
Precisely. It's this beautiful coordination between the humerus moving and the scapula moving that gives us that incredible range of motion.
Right.
And to loop all the way back to our earlier clinical puzzle.
Ah, yes, the flattened shoulder.
The flattened shoulder and that regimental badge, numbness.
Axillary nerve damage.
Bingo. Points directly to axillary nerve damage. Likely cause...
A shoulder dislocation or a surgical neck fracture.
Perfect. See how knowing the anatomy, the nerve paths, the muscle actions, and the common injuries all fits together. It lets you take those clinical signs and symptoms and work backwards to the likely cause.
Absolutely. It's like solving a puzzle.
It really is. Wow. Okay, that was quite a journey through the posterior trunk and shoulder. We've seen how the back is so cleverly layered. Extrinsic muscles for big limb movements and breathing. Intrinsic muscles for that deep postural support and fine spinal control. And then the shoulder, so powerful, so mobile, with the versatile deltoid and that absolutely critical stabilizing team, the rotator cuff.
Yeah, understanding these relationships, especially those distinct nerve patterns, anterior versus posterior rami, and the clinical weak spots like the axillary nerves path or that supraspinatus tendon under the arch, It's truly foundational knowledge. It's not just memorizing lists of muscles and nerves, it's seeing the whole system working together. And importantly, understanding what happens when that harmony gets disrupted, that holistic view. And that's what makes an effective clinician.
Couldn't agree more. You've now got, hopefully, a much better toolkit to recognize and understand why our backs and shoulders move the way they do, and sometimes, sadly, why they don't move right. You're building that mental map, that framework, to approach patient problems with more confidence. So for your next step, as you go about your day or your studies, here's a final provocative thought for you to chew on. Next time you're in the gym, or you just see someone doing a really challenging overhead press or maybe a powerful pull-up, can you try to visualize that intricate dance happening under their skin? Can you see the extrinsic back muscles, like the lats, extending the humerus, and at the same time, the scapular rotators, like the trapezius serratus anterior, ensuring that full range of motion, and all the while those deep intrinsic muscles are firing like mad to stabilize the spine against that heavy load. Just think about how all those different groups, extrinsic, intrinsic, scapular movers, have to work together in perfect coordination to create such a powerful, smooth action. It really is a marvel of biological engineering when you stop and think about it. Okay, that's it for this deep dive. We really hope you're feeling a bit more clued in, a bit more ready to tackle your next anatomy challenge. Until next time, keep exploring.